Hello everyone, so we will be doing chapter 17 of illustrated textbook of Pediatrics, which is respiratory disorders, features of respiratory disorders in children. Respiratory disorders are common in the UK. They account for half of acute consultation with general practitioners in young children. Respiratory disorders are the commonest causes of acute pediatric hospital admissions. Asthma is the commonest chronic childhood illness in the UK. Modern management of cystic fibrosis and markedly extended life expectancy. Predisposition to individual respiratory disorders varies with age. For example, type of acute respiratory infections children experience at different ages, as shown in the picture. Infants and young children are particularly susceptible to viral infections following loss of protective maternal antibodies. Age also affects the severity of illness. In general, neonates and infants are the most severely affected. The growing lines of children are also particularly vulnerable to the long-term effects of environmental pollution and toxins, including cigarette smoke, which increases the lifetime risk of several diseases, including asthma and chronic obstructive pulmonary disease in adult life. Risk factors for respiratory disease in children or young people include parental genetic risk of switching to smoking during pregnancy in the child and young person, prematurity or low birth, especially with bronchopulmonary dysplasia, congenital heart disease, disorder causing muscle weakness, reduced immune function, lack or incomplete immunization or cigarette use and vaping. Environmental household or air pollution, number of siblings, allergens, a lower socioeconomic status, cigarette smoke, and vaping. And the presentation of respiratory disorders in children can be a bit older, with the clinical features of upper respiratory tract, coryza, sore throat, earache, sinusitis of first rider, lower respiratory tract, which includes a cough. The character and nature of the cough is uh, suggests a particular disease. Internal wet or moist cough suggests that they are extra secretions. Increased rate of breathing while the normal ranges for respiratory are wide, particularly in children. Tachypnea is one of the most sensitive signs of illness. However, this is not specific for respiratory problems and also in heart failure, metabolic disorders, and sepsis. Age distribution of acute respiratory infections relative in the incidence is given pneumonia, bronchiolitis, viral flu. Ages are given upper respiratory tract infections. Uh, these are the age distributions, increase, the marked study sessions of an effective picture, and you get the increased work of breathing. Increased work, effort of breathing, increase in resistance in the area of lungs will result in increase in the effort required to achieve adequate gas exchange. The conscious child would try to keep blood, carbon dioxide, and oxygen levels normal. Resistance is increased in upper airway and effort is increased in inspiration. Resistance increase in the lower airway and effort is increased in expiration. There's a specific indicator. This is a specific indicator of respiratory illness. Chest recessions in fixed reaction, as is shown in picture. Chest is an important indicator of increased work of breathing as they have compliant chest walls. It is dynamic, with each breath due to an acute change in effort required to overcome air resistance. The recession can be above the ribs, substernal, involved chest wall, sternal, or below the subcostal, below the ribs, either subcostal, suprasternal, or sternal. As chest wall muscles are relatively weak and the diaphragm is relatively strong, when the work of breathing increases, the breathing pattern becomes abdominal. This leads to a seesawing of the chest and abdomen, with the chest moving in, whilst the abdomen moves out during inspiration. This contrasts with later childhood life, and even if there is increased vocal breathing, this stiffer chest wall and diaphragm move together with both moving outward during inspiration. While recession can still be seen, it tends to be between the ribs, which is intercostal. And extra respiratory noises, flow of air against the resistance will lead to generation of sounds. Stethoscope makes lower airway sounds easier to hear. Musical noises, breeze suggest partial obstruction of pore sounds. Crackles suggest increased secretions. And reduced oxygen saturation in air. This is a sensitive marker. This is a sensitive marker or respiratory oxygen saturation can also be low in children with cardiac conditions, but it is less likely to increase to the normal range of supplemental oxygen, especially designed probes are required according to the child's size. And impending respiratory failure is suggested by cyanosis, persistent grunting, which is sound, reduced oxygen saturation despite oxygen therapy, and a rising CO2 and bad gas, and exhaustion, confusion, reduced conscious level. And additional respiratory support will be required. Now, the summary of it is given. Clinical features for each of the problem for the junction and cough, respiratory noises, which are wheeze, strident freckles, and then there are wheeze is basically partial obstruction, and in the case of freckles, it is suggests that they are secretions. Increased rate of breathing, increased work of breathing, dynamic chest recession, which are intercostal, subcostal, reduced oxygen pressure, improves with supplemental oxygen respiratory support if necessary. Now, the upper respiratory tract infection, we have an average of 5 upper respiratory tract infections per year in the first few years of life, but some infants and primary school children have as many as 10 to 12 per year. Approximately 80% of all respiratory infections, upper respiratory tract infections, determine basis on a number of different conditions. Common cold, which is coryzal symptoms, and sore throat, pharyngitis, including tonsillitis, and acute otitis media and sinusitis, relatively uncommon. The child may have a combination of these conditions. Cough may be troublesome and may be secondary to attempts to clear upper airway secretions or postnatal trip. Upper respiratory tract infection may cause difficulty in feeding in infants as their noses are blocked, and this obstructs breathing for seizures. Hospital admission will require feeding and fluid intake is inadequate. The common cold, which is a coryza, is the most common infection of childhood with classical features, including clear or mucopurulent nasal discharge and nasal blockage. Most common pathogens are viruses, rhinoviruses, of which there are more than 100 different serotypes. Coronavirus and respiratory syncytial virus, RSV. Advice of parents that colds are self-limiting and there is no specific curative treatment may reduce anxiety and save unnecessary visits to doctors. Pain is best treated with paracetamol, ibuprofen. Antibiotics are of no benefits. The common cold is viral infection and secondary vector infections is very uncommon. Cough may persist for up to 4 weeks after a common cold. Sore throat, pharyngitis, with tonsillitis and pharyngitis usually caused by viral infection, adenovirus, entero, or rhinovirus, and results in inflammation of the pharynx. The soft palate will variably enlarge and tend to local lymph nodes. Tonsillitis is a form of pharyngitis causing intense inflammation of tonsils or with a prurence X-rate may be caused by group A, beta hemolytic streptococci, and EBV, Epstein-Barr virus, infectious mononucleosis, or glandular fever. Tonsillitis of group A, beta hemolytic streptococci may produce a toxin responsible for the rash of scarlet fever. In the figure 15.9a in chapter 15 that we've seen, marked constitutional disturbance such as headache, apathy, and abdominal pain is more common with bacterial infection, but it is not possible to distinguish clinically between viral bacterial causes and less than a third of cases of tonsillitis that are caused by bacteria. Antibiotics such as Penicillin, erythromycin, hasn't recovery from streptococcal tonsillitis on average by only 16 hours. However, antibiotics may be indicated to eradicate beta hemolytic streptococci to prevent rheumatic fever in high incidence countries or in children at higher risk of severe infections. It requires 10 days of oral antibiotics. Really, children may require hospital admission for IV fluid infiltration and analgesia if they are unable to swallow solids or liquids. Amoxicillin is best avoided as it may cause a vice-vermiculopoccal rash if the tonsillitis is due to infectious mononucleosis. So basically, infection mononucleosis, which is caused by EBV, amoxicillin is avoided. Why? Because it causes rash. Children with recurrent tonsillitis or its complications which are peritonsil abscess, quinsy, and those with sleep disordered breathing, that is obstructive sleep apnea, may benefit from tonsillectomy or adenotectomy. However, as acute surgery is very common in children, not to prevent unnecessary surgery strict indications for the operation have been blocked. In some countries, UK surgery is usually deferred until a child has had 7 or more episodes of significant surgery in the preceding 12 months, or 5 or more episodes in each of the 2 previous years, or 3 or more episodes in each of the previous 3 years. So basically, surgery is deferred if until a child has had either 7 or more episodes in the preceding 12 months, or 5 or more episodes in the previous 2 years, or 3 or more episodes in the previous 3 years. Tonsils and adenoids increase in size until about 8 years of age, and that gradually regress. In young children, the adenoids grow proportionately faster than the airway. Narrowing the airway is safe for greatest between 2 and 8 years. For children where sleep disordered breathing is suspected, parents should be encouraged to obtain video recordings of children during sleep, as these can help make decisions about the need for sleep recordings or surgery. The next one is acute otitis media. Infants and young children are prone to acute otitis media because the eustachian tubes are short, horizontal, and function poorly. Most children will have at least one episode of acute otitis media, and up to 20% will have 3 or more episodes. It is most common in 6 to 12 months of age. It causes earache and fever. Acute otitis media diagnosed by examining the primary brain, which is visualized in all febrile children. Antibiotic marginally shortens the duration of do not reduce hearing loss. Recurrent may result in otitis media with a fusion, which may cause speech and learning impairment from hearing loss. Every child with the fever should have the entire tympanic membrane examined. In A to D, it is shown appearance of the eardrum, and normal is number A. B is acute otitis media with fusion, and that is a grommet placed. Sorry, it's shown in picture. In the acute otitis media, the perineum membrane is bright red and bulging with loss of normal light reflection. Occasionally, there is acute perforation of the eardrum with pus visible in the external canal. And pathogen are RSV, rhinovirus, pneumococcus, Haemophilus influenza, and Mrcpch Fop. Complication including mastitis and meningitis, but these are rare. Pain should be treated with regular analgesia and may be required for up to a week. And otitis media usually resolves spontaneously. Antibiotic marginally shortens the duration of pain, but have not been shown to reduce risk of hearing loss. Neither teaching medicines nor antihistamines are beneficial. And recurrent ear infection can lead to otitis media with effusion, also called the blue ear, which is shown in the picture as well. That is the blue ear. Children are usually asymptomatic apart from possibly decreased hearing. The eardrum is dull and retracted, often with a visible fluid level. Otitis media with effusion is very common between age of 2 and 7, usually resolves spontaneously, but may cause conductive hearing loss and interfere with normal speech development. There is no evidence or long-term benefit from the use of antibiotics, steroids, or decongestants. Nasal inflation, where the child breathes out through nostril to create a small balloon, may help by opening the eustachian tube, but the child usually needs to be school-aged to form it. If hearing does not improve, surgery may be considered with surgery on tympanostomy tube, which is grommets. They are placed in the developing brain with or without involving adenoids, but benefits often do not last more than 12 months. Sinusitis, infection of the paranasal sinuses, may occur while upper respiratory tract infections. Occasionally, there is secondary bacterial infection with pain, swelling, and tenderness over the cheek from infection of respiratory sinus, as the frontal sinus do not develop until later childhood. Frontal sinusitis is uncommon at the first decade of life. Antibiotic analgesics are used for acute sinusitis. Upper respiratory airway obstruction, severe upper airway obstruction results in choking. To clear the airway, complete obstruction of the upper airway rapidly leads to respiratory failure and death. It may occur acutely as a result of inhaled foreign body inhalation burns. Partial obstruction of the upper airway leads to increased work of breathing accompanied by additional noises of breathing. Variable upper airway obstruction leads to stutter, snoring when asleep, and fixed partial airway obstruction leads to stridor, high-pitched musical airway whistling sound. Brief explanation of why upper obstruction leads to stridor rather than wheeze is given in figure 17.4. Causes of dry eye listed in box simply by one. By far, the most common cause is viral pancreatitis. Common causes of acute stridor are either croup or foreign body. The most common causes. The next causes, the rare causes, which are in the what do you call it? Table. So as it is laryngeal edema, anaphylaxis in a recurring group, inhalation of smoke and hot fumes and fire, trauma to the throat, retropharyngeal abscess, bacterial hepatitis, severe lymph node swelling, malignancy, tuberculosis, leishmaniasis, measles, hypocalcemia, mental heart dysfunction, diphtheria, bleeding rare. And the severity of the restrictions best assessed clinically by corrections to the side and none, either none, only or crying, at rest, or palpitation. And degree of accompanying chest restrictions, none, only or crying, or at rest. Severe obstruction also leads to increasing respiratory rate, heart rate agitation, central cyanosis, drooling of saliva, from inability to swallow it, or reduced level of consciousness, suggests impending complete airway obstruction and the need for intubation. Pulse oximetry can reliably detect hypoxemia, but in contrast to parenchymal lung disease, it is a late feature in upper airway obstruction. Total obstruction of the upper airway may be precipitated by examination of throat using spatula or while looking at the throat trial with upper airway obstruction, unless full resuscitation equipment and personnel are at hand. In normal breathing during inspiration, negative intraocular pressure dilates during inspiration and expiration, the intrathoracic airways, but collapses the extrathoracic airways. And on expiration, posterior intraocular pressure does the opposite. This explains why extrathoracic obstruction causes difficulty in inspiration, whereas intrathoracic obstruction causes problems on expiration. Number represents pressures at different points. Now, the group divided accounts for 95% of medical tissue infections in children, where influenza is the most common cause, but being treated by rhino, RSV, and influenza. Occurs from 6 months to 6 years of age, but the peak incidence is in the second year of life. It is most common in the autumn. The typical features are coryza and fever, followed by constitutive inflammation of the vocal cords, a bumping cough like a sea lion due to tracheal edema and collapse, and harsh stridor, and variable degree of difficulty breathing with chest recession, symptoms starting and being worse at night. When the upper air obstruction, mild stridor and chest recession disappear when the child is at rest, and the child can usually be managed at home. Parents should be advised to observe the child closely for signs of increasing severity. Decision to manage the child at home or in hospital influenced not only by the severity of illness, but also by the time of day, ease of access to hospital, and the child's age with lower threshold for admission for those less than 12 months due to their narrow airway caliber and parental understanding and confidence about the disorder. Inhalation of warm, moist air is traditional and widely used therapy, but it has not been proven to be beneficial. Oral dexamethasone, oral prednisone, and nebulized steroids, budesonide, reduce the severity and duration of improvement. either one is first-line therapy. For group causing chest recession at rest, there has been shown to reduce the need for hospital. Its upper airway suctions where nebulized epinephrine, adrenaline, or oxygen by face mask provides rapid but transient improvement in the child. Must continue to be served closely for 2 to 3 hours. Administration and its benefit is temporary. When the therapy is useful, lies waiting for the corticosteroid to take effect. Intubation for violet tooth has been extremely unusual since the introduction of steroid therapy. Some children have a pattern of recurrent intubation may be related to be Pediatrics and acute complications. Pediatrics epilepsy has similar clinical features. The latter is now very rare in children in most countries and the can see type B. Presentation is very ill-looking child with high fever, drooling saliva as they're unable to swallow and tries to prove this child is soft. The case history is in children with bacterial tracheostomy have copious thick air secretion. They have rapidly progressive air obstruction. Bacterial tracheotitis is typically caused by infection with staph aureus. If the diagnosis is either bacterial tracheotitis and is suspected, urgent assumption that treatment is required, calm and restriction of oxygen with nebulized adrenaline will usually offer some therapeutic benefit. Treatment must be initiated without delay. A senior anesthetic dietitian ENT surgeon should supervise maintenance of pain in the child should be intubated in a controlled condition with a general anesthetic. Really, this is impossible. Urgent diagnosis is required. Only after the airway is secure should blood be taken for culture and intravenous antibiotics started. The case the accused rider, Amira, 14-month-old girl, woke up at 2 a.m. with marked noisy big inspiration and loud. She has been well and she had been well until the evening when she developed a runny nose and fever of 38.1. Her mother gave her a dose of paracetamol suspension. Her noisy breathing scared her mother, who called an ambulance at the emergency department. She was noted to have a temperature of 7.9. It was alert but had marked respiratory stridor and moderate chest recession, particular inspiration. What diagnosis would you make and how would you manage it? A diagnosis of white troop was made. The history is characteristic, including the stridor being worse at night. She does not have the clinical features of tonsillitis or bronchitis, which are important to exclude. Management in accordance with her disease severity is given a single dose of steroids, either orally or nebulized. She was given oral dexamethasone followed by observation and 2 hours were discharged from the cancer stridor and the bleeding has improved. Clinical features of troop and tracheitis. Onset is over days, about troop, about tracheitis over hours, visiting Pariza, yes, and cough in troop and cough severe barking and tracheitis absence of sight, able to drink and improve the yes, but in difficult swallowing and the during saliva is present and appearance is unwell. In troop and it's toxic, very looking fever is less than 3.5, was more 3.5. In bacterial and stridor is harsh, rasping, soft whispering in bacterial tracheitis and epiglottitis, and voices is hoarse and muffled, reluctant to speak. This is a child with acute stridor. Clinical pediatric says is no fever, doesn't have barking cough, this is cyanosis, suggestion checked, toxic ill-looking, exhaustion, level of consciousness, drooling, saliva, stridor, only crying, interest of biphasic, chest recessions, mild, only crying, severe, marked stridor recessions even at best. Other causes of a child with acute stridor presents with atypical features or a poor response to treatment, other causes need to be considered. If child has an abrupt onset of stridor without infection, consider anaphylaxis in the foreign body. Chronic stridor is usually due to structural problem either from intrinsic lateral collapse of the laryngotracheal airway, laryngomalacia of the larynx, subglottic stenosis or external compression, vascular ring where the trachea and esophagus are compressed by blood vessels, most often a double aortic arch, lymph or tumors. Investigations are sometimes required to determine the cause. Laryngomalacia is common and is due to soft, immature cartilage of upper larynx, perhaps an uninspiration cause of air obstruction. Although it is congenital normally, it is usually present at about 4 weeks of age. Respiratory fluid is sufficient to generate this flight, which is worse The infant is agitated, feeling, or lying on his or her back. If the child is thriving, no treatment or further investigation required to resolve. Solves by 2 years of age. So next, lower respiratory tract infection we will do in the next video. Thank you very much.